This week on the Backtable Podcast.
It continues to boggle my mind how difficult it is to get through the FDA with an injectable, right? Where, to get a targeted fluorophore into the operating room with, safe, completely safe, not even a theoretical risk of harm, it's this years-long process. Whereas to get a device like an ablation machine into the OR, you just have to show a lack of harm. It amazes me how difficult it is for drugs and how easy it is for devices. You just have to show that this will not cause direct harm to the patient. You don't have to show a single thing about efficacy. And that's just the nature of our regulatory environment, which is different in other countries.
Hello, everyone, and welcome back to the Backtable Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsor. From concept to completion, there's a lot to consider when building a Theranostics or PSMA PET-CT imaging program. It's nearly impossible to be an expert in every aspect of this care pathway, but the success of your program depends on it. Get the support you need from an experienced team. Open your web browser and search Siemens Healthineers Theranostics. You'll see the complete Theranostics care pathway and how they can help you customize it to meet the needs of your prostate cancer patients. Visit their website or stop by Siemens Healthineers booth at the local and national American Urological Association and large urology group practice association meetings. You deliver the care, they'll deliver the rest. This discussion is brought to you by Veracyte, provider of the Decipher Prostate Genomic Classifier. Decipher Prostate is a test for patients with localized prostate cancer that can help personalize treatment. Every patient and their prostate cancer is unique, and Decipher Prostate can provide meaningful insight into the aggressiveness of each individual's patient's tumor. Because the Decipher score is derived solely from the genomic characteristics of the tumor, it provides information not available through already known clinical and pathologic factors. Decipher high-risk patients generally benefit from earlier or intensified treatment, while Decipher low-risk patients may be ideal candidates for monitoring or less overall treatment. Decipher Prostate is the most validated gene expression test in localized prostate cancer, with level 1 evidence in national clinical practice guidelines and more than 70 peer-reviewed publications, including more than 65,000 patients. Visit Veracyte.com/Decipher to learn more. Now, back to the show. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guests today. We have Matt Cooperberg from UCSF, and we have Arvin George from Johns Hopkins. Matt, Arvin, how are y'all doing today?
Good. Pleasure to be here. Thanks for having us.
Perfect. Well, we're going to get some different perspectives, an East Coast perspective, a West Coast perspective on focal therapy. And I thought we'd kick off with, so Matt, you're a UCSF lifer.
You can stay forever, UCSF.
You can stay forever. Perfect. And did you actually do focal therapy as a part of your training, or did this kind of come, into your attending hood?
I would say minimally. We have been doing focal therapy at UCSF under Katsuhiro Shinohara for a long time, but very sparingly. When I was in training, it was mostly a question of focal cryotherapy. HIFU was a 4-letter word at UCSF when I was in training based on the early generation machines and the early generation data, to be sure. So we had some exposure to focal therapy. It was something like 100, 120 cases over about a decade. So to an extent, but obviously there's a lot more interest and a lot more exciting research and development going on now.
Got it. And Arvin, so residency, LIJ, is that right?
Yep, that's right. Now it's Northwell Health, but yeah, LIJ.
Okay, and during residency, did you do much focal? Where were things in that?
No, it was still at that point, weren't doing much focal. I wrapped up residency around 2012. So it was still early. It was actually, kind of early adoption of fusion at that time point. So, I think really fusion biopsy and image-directed biopsy really preceded the growth of focal.
And how about in your fellowship at the NCI?
Yeah, at the NCI, it was also sparing. We were starting with our initial focal laser ablation protocol. It was an in-bore laser ablation, and there was a number of studies from other institutions, including the University of Chicago, which looked at that previously. But again, just a handful of cases at that time during fellowship.
Honestly, before starting here at UCSD, not only had I never done a focal therapy, I'd never seen one. And I would in no way, shape, or fashion put myself in the same category as you both in terms of, really being thought leaders and pioneers in this field. But I think it's nice that I always found it to be a little bit foreign, intimidating, that you can sink your teeth into it and kind of learn it. And maybe we'll kind of get to that. Well, let's just start with some basics. Focal therapy definition. How do you define focal therapy? Or is it ablation? Is that the better term?
There's some semantics that surround it, and there have been some attempts at trying to clarify the terms. But there's partial gland ablation, which is kind of the overarching umbrella term, which is anything that's a subtotal ablation. And then focal therapy, in my mind, is really treatment of the index lesion plus a safety margin that I typically employ is about one centimeter or more.
Matt, does that sound about right?
Yeah, I would totally agree. But to emphasize Arvin's point, the terminology is used highly, highly variably across the literature. Siemens in Asia had a nice classification, which I'm sure many others have used as well, which is, focal, truly focal being exactly what Arvin just described, a visible lesion with some margin around it. It could be hemiablation. Others will do hemi plus, the other side. I've seen some where they do hemi plus almost the entire side, just sparing a little bit of tissue around the NVB and still call that focal. So you can see the term kind of used and abused in lots of ways. And it's one of the things that has made the literature a little bit difficult to track.
Yeah, whole gland ablation, hockey stick ablation, hemi-gland ablation.
It's a spectrum, right? It's just a spectrum from A to Z. And, we feel compelled to call it different names to help clarify if we're comparing apples to apples, I guess.
So, Matt, I think I kind of was chuckling when you said that HIFU was a 4-letter word. For much of my kind of training career, focal therapy was this like gimmicky deal that people in Florida were doing for cash pay, and then they'd wind up at like a normal center where everybody, high grade, low grade, surveillance candidates, high risk for getting ablation. And I guess we just saw kind of these like catastrophes. And, the state of the art seems to be improving, imaging, all of that. And of course, we'll talk about that. But what about just guidelines? What do our U.S. guidelines say? Is this experimental? Is this, ready for prime time?
The guidelines are, I think, appropriately pretty sparse in terms of what they say about focal. It is still experimental to an extent, right? And the guidelines are pretty guarded in their endorsement of focal as an option. There are no focal therapy, explicit focal therapy guidelines that have been adopted by any national organizations. There are a variety of society guidelines and statements that have been put out. We just had one out from the 5 University of California sites, which of course you were part of, which does emphasize the point that patients should be told this is not a treatment with nearly the same duration of follow-up, with nearly the same validation data that the standard treatments, surgery, radiation therapy, active surveillance, have. So, we don't call it experimental in the sense that this is, first in human research, and it can be done outside of the setting of an academic institution. And that's, I think, a big part of the problem in the field is the way it's being done across the community practices. And the guidelines do say we should be tracking these patients in a trial or a registry to collect better data about outcomes. So it's a rapidly evolving space without a lot of hard guidance reflecting the state of the literature.
What do you think, Arvin? You think the guidelines are...
Yeah. So, it's your two key guidelines are going to be the AUA and EAU guidelines, and either they say that it should be done within a well-designed prospective cohort or within a comparative study or clinical trial. It does in the salvage space. NCCN does include HIFU and cryo as a salvage treatment option. But I agree, it should be exercised with caution. And I'm not sure it's necessarily a community urology problem. It's just a lack of urology knowledge problem. This is, like you said, this is a field that, we're taking a bite out of now, and we're really starting to study it and understand it. And, things that may seem obvious to us, maybe as academics, 10 years from now, we're going to look back at it and say, what were we thinking at that time? So, I think it's a period of learning for all of us. And I think we have to accept that and be very, brutally honest about it to ourselves and to our patients.
One part of the problem, if we take a step back even from the guidelines, is just the regulatory environment here. And it just reflects the fact that, it continues to boggle my mind how difficult it is to get through the FDA with an injectable, right? Where, to get a targeted fluorophore into the operating room with, it's safe, completely safe, not even a theoretical risk of harm, it's this years long process, whereas to get a device like an ablation machine into the OR, you just have to show a lack of harm. It amazes me how difficult it is for drugs and how easy it is for devices. You just have to show that this will not cause direct harm to the patient. You don't have to show a single thing about efficacy. And that's just the nature of our regulatory environment, which is different in other countries. So, once it is kind of out there, well, it can be used for lots of different things without IRBs, without protocols, without being in a trial. So if you look at how focal and ablation modalities have been rolled out over the last 20 years in the States, and I should say across North America, if you look at the experience of folks taking their patients ex-US to Canada and Mexico to do HIFU in the 2000s, it's a history now that doesn't look great for us in terms of the way we have rolled this out. And I think there's a lot of horror stories out there, as you were just talking about. So, we're now getting just to the point where we actually have prospective studies, some trials, and, academic centers started to take this seriously. But in a way, we're playing catch up with a field that really has been Wild West for quite some time.
Well, and it does kind of dovetail, because without that kind of disease-specific CPT code that's not going to get covered by insurance, that leads to cash pay and maybe makes it more or less appealing without kind of, going too far down that rabbit hole. All right, so, I think the guidelines are pretty reasonable, kind of cautious, but not quite as negative on focal, if you will, as they once upon a time were. Grade group 1, so let's stick to surveillance. High risk, let's stick to our standard options. Intermediate risk, it's a bit of the, maybe a bit of the conversation. Well, let's talk about ideal patients, and maybe we could talk about patient-specific factors, prostate and anatomy-specific factors, and then some cancer characteristics when you're thinking about focal. And I'll just throw this out there. When I moved here to San Diego, they had recently purchased a machine to perform HIFU, and part of my charge was to help get that going. And I was waiting for a solitary MRI, visible, peripheral, posterior lesion, 3 + 4 = 7, 1 or 2 cores. Fast forward a year and a half, and I'd done 1 focal therapy. And I actually thought the patient would have done fine on surveillance. So maybe just with that context, ideal patients.
I'd say you just described it, right? And like you said, there's not that many of them. I think the band is fairly narrow for the ideal focal patient, because you need somebody who needs treatment. They're not a good surveillance candidate, but you need somebody who doesn't need whole gland treatment, where you're not worried about the field effect, the field defect in the prostate genomics. You're not worried about the lymph nodes and the pelvis and all the rest of it. So, and that's not a particularly wide, band of the risk profile. So I think it's, again, what you described. You want imaging visible, either on ultrasound or MR, ideally on both. You want to find 3-4, maybe limited 4-3 in that lesion. We will accept 3-3 in other parts of the prostate, but ideally no higher grade disease outside of the lesion unless it's immediately adjacent. In the University of California protocol that's out there, and certainly at UCSF, we definitely strongly encourage confirmatory biopsy with MR guidance if the initial one was done without MR before committing to focal. And we're trying to get genomics on everybody and encouraging folks with high risk genomics, potentially to consider whole gland therapy. And I would say one thing that the other selection criteria, the patients really need to understand that this is not an alternative to surgery or radiation therapy if we're not talking about whole gland treatment. I think about it as an augment to active surveillance for patients who are not otherwise great surveillance candidates. Everybody is committing, or they should be committing, to a biopsy 1 year later, no matter what happens with the PSA and imaging. And we have to follow them for life. They can develop a recurrence, they can develop a brand new tumor. So they really are on more of a surveillance path, hopefully with fewer biopsies and a lower chance of disease progression than if they were on pure AS. But this is more, in my mind, this is more active surveillance plus than it is alternative to prostatectomy or radiation.
Yeah, I think that you covered a lot there, Matt. Arvin, and maybe I'll ask you, it's kind of both ends of the spectrum, right? You're the young, healthy patient who's quite functional, that you really want to limit the potential adverse effects of surgery, radiation. The opposite end of the spectrum, you maybe have an older, sicker patient that merits treatment and that you don't want to put them through whole gland treatment. How do you kind of think about that spectrum?
I think I'm probably a little bit less conservative than Matt, in that I would apply to all intermediate risk, but I do believe there needs to be some guardrails up. And so typically either a PSA less than 15 or a PSA density less than 0.2 do know that recurrence rates do increase at that kind of it's a bit of an arbitrary threshold. I don't treat low-grade disease, and I'm also relatively aggressive in putting men who have favorable intermediate risk on surveillance if they're appropriate candidates. And so there are all these disease characteristics which are really, really important. But with any treatment, I believe that, the higher the risk, the disease is, the outcomes are going to be worse. And that is the same for surgery or radiation. Mechanistically or procedurally, if there is a cancer that is isolated and I feel that I can destroy it and achieve a reasonable margin, there's no reason that prostatectomy would be superior. So I do think in the future that we will be able to treat high risk. And there are some series that have already included high risk. I don't personally treat that in my practice right now, but I do think that as data accumulates, and it'll largely be out of a number of clinical trials that are already underway, that will really give us the signal as to where we can and we can't do it. And then one piece I think that Matt did not mention that, of course, is obviously at the top of all of our minds is the patient perspective. A lot of times patients are coming to us asking us about these treatments because of the limited morbidity. And so to a certain degree, we have to protect patients from themselves. But at the same time, we also have to be able to understand the patient's perspective and let them also take part in that decision between the trade-off between cancer outcomes and functional outcomes.
Totally. And I have here in my notes the patients insisting on focal, and we can maybe talk about that. I don't know how it is at your institutions, but we get these new technologies, everybody gets excited. Then there's a press release that everybody and their brother come in wanting new treatment. So we talked a little bit about, the patient-specific factors. Significant BPH, is that potentially going to be benefited? Is that going to cause problems?
I don't think it makes a difference. It's going to be technology-specific, and it also depends on the volume of tissue that you actually have to ablate. If you're going to have to do a hemi-ablation in a 120-gram gland, that's not going to be a great candidate, versus if you have a very discrete image-visible lesion, target-only positive. BPH actually gives you the ability to achieve a nice wide margin circumferentially, and a lot of times improve some of those symptoms marginally, moderately, I would say, in terms of lower urinary tract symptoms on 4 to 5 points on an IPSS, and in some cases, depending on the volume of tissue that you ablate.
I think I worry more about their baseline IPSS than on the volume per se. And of course, I'm sure we'll get to this, but the anatomy beyond just the size of the prostate does matter. If the lesion is closer to the apex, closer to the urethra, more medial, etc., we're going to worry a little bit more about the urethral impact, especially in somebody who's got baseline obstruction.
Totally. We're going to get to the modalities and some of those specifics. Bilateral disease, bilateral intermediate risk disease, is that deal breaker, not a big deal?
I don't really treat bilateral disease. I think that if you're going to approach, essentially what are you really achieving here in terms of what are you sparing? And in those cases, I think that if it's the side effects of focal therapy specifically regarding continence and sexual function, then I would say that radiation is going to align best with their goals of care rather than a radical prostatectomy. But yeah, that's kind of, those are my thoughts, yeah.
Okay, so I think we touched on grade, focality, bilaterality, locations we'll talk about, PSAs, something reasonable, PSA densities.
I do think that whole gland ablation is probably underutilized. We have patients who aren't great surgical candidates, older patients who we would otherwise deliver radiation to. And, maybe we don't need to achieve, 10 years. Maybe we want to keep them not metastatic for a period of time. And, really, if their life expectancy is greater than 5 years, it's really radiation that's recommended anyway. So I think that you have the opportunity for some people who don't have access to a radiation center or live closely within it. The skill set is not tremendously challenging, again, in select patients.
There was just a little bit of a, usual kerfuffle on Twitter after Scott Eggener just reported their phase two prospective series, exactly, of TULSA, and there were a couple of usual suspects, radiation oncologists, getting very aggravated about the data, and this is experimental, and I don't have to go. Why are these patients just getting radiation therapy, right? And you can imagine who said what, and I will say when I was in training, we're talking about training, we used to do whole gland cryo to a very limited extent, I would say, in my early training, but the outcomes were consistently worse than what we would see with radiation, or frankly, what we would see with prostatectomy done in a high volume center. So it really sort of fell by the wayside. And I worry a little bit about the variability of the outcomes. A lot of patients do great, but some of them clearly do not. And I'm not sure that we have the tools to predict, especially with whole gland. And it's the patient that is, quote unquote, too sick for surgery. you wonder how many of them are really at risk of dying of prostate cancer in the near future. 5-year life expectancy, to me, that is incredibly narrow, and that is what the NCCN says. I agree. But if your life expectancy is 5 years, you really should stop thinking about the word prostate in your list of life concerns, as far as I'm concerned. 10 years, maybe,
And this, I might have missed this, MRI invisible, is that a deal breaker, big deal?
Yeah, I'm not a huge fan of treating MR invisible disease. Now, I know there's different camps on this, and I think that there's a little bit of cognitive dissonance in my thinking, but my concern is that if you're treating MR invisible disease, then how confident can you be that in the areas that you did not sample that were also negative on MR does not have disease? Now, that can be true even if you see a visible lesion, but I think that the equation changes a little bit, and at least in my mind, I'm a lot more comfortable treating somebody. And the other thing is, how do you follow those men apart from PSA? I think that imaging is a powerful tool in the surveillance setting as well. So having a target to treat, I think, is very helpful. And I do think that it's a phenotype, and it does speak to the biology of the disease to a certain extent as well. So MR visible disease is in my opinion, going to prove to be more clinically significant. And maybe it's a volume issue, maybe it's a grade issue, maybe it's a bit of both.
I'd agree. I think there will be some exceptions if you have clearly unilateral disease, at least, and it's been well sampled. And again, confirmatory biopsy confirms unilateral, and you're going to think about hemiablation. I'm fine with that. Now, again, the patients need, in our protocol, the patients need at least that 1-year biopsy, even if the imaging looks fine. So, so I wouldn't say it's an absolute deal breaker, but it's a fairly uncommon scenario these days where the MR is truly negative and they have clinically meaningful disease that needs to be treated. It does happen, but we're talking about very select patients at this point.
And we do have the advantage of additional imaging like PSMA PET and unfavorable intermediate risk. So I think it needs to be visible on any imaging modality. So I think we have, additional tools.
Ideally, we see it on ultrasound as well, by the way.
Are you all using micro-ultrasound, just out of curiosity?
Yeah, we have it, and we've been using it. I'm getting myself trained on it. I'd like to participate in the Optimum trial. We have it up and running already, and I'm hoping to get more experience with it. I think that the Optimum trial will give us a lot of insight as to its value in comparison to MRI, and I think it's promising.
I've done a few. I like it as a modality. It's definitely a learning curve. It's a very different picture than we're used to seeing with the conventional ultrasound, even the high resolution ultrasounds that we've had, sub 44K high resolution ultrasounds. So there is that learning curve. I think it's got a lot of appeal in places where there's not easy access to high quality MR. I think a urologist that's well trained on this is going to do a much better job than let's say, marginal quality or mid-quality community radiology center where they're doing mammograms in the morning and a couple prostates a week in the afternoon. But there's a lot of validation work that has to be done. It is a learning curve, to be sure.
Yeah, we have it here as well, and it's just right there next to our UroNav, and I'll complete my UroNav, take a look, and see if there's anything that I could have picked up, or just trying to educate myself, because the modules are great. Not to digress too far, but Starry Night, medium smudge, fingerling potatoes. I'm like, oh my God, I can convince myself of just about anything. Okay, so that does take us into...
So you do both. You do both. You do an ultrasound, you do your UroNav with the standard ultrasound, and then do a...
Yeah, I just tell them I'm going to take one more look, and if there's anything else, and I'll just mark it as additional
UroNav biopsy.
Yeah, micro-ultrasound target, and then I'll look at that. Okay, so we started kind of talking some about the workup here. Matt, you mentioned a confirmatory biopsy. I think it's a foregone conclusion everybody has an MRI. Are you guys, in somebody that you're maybe thinking that this could be a focal candidate, halo biopsies, penumbra biopsies, can you walk us through that?
Yeah, I don't know who's going to be a focal candidate before, and so I don't routinely do that. But what I do when I sample a target is I sample across the lesion. So if it's whatever it is, if it's, whichever system that you're using, I'm not going to sample if it's UroNav the bullseye over and over again, because I'm just over-representing what I already know about. So rather, I'll actually map it across the lesion, typically every 3 to 5 millimeters, depending on the size of the lesion, both in the anterior, posterior, and medial lateral directions.
Okay. What about you, Matt?
Yeah, I think this is an evolving concept. I think it has a lot of appeal to it. I think our institutional experience has guided us just to be putting wider margins on the lesions in general. I have not started to. I've seen a few studies recently on halo biopsies or penumbra biopsies. It makes a lot of sense in terms of planning the size of the lesion. One concept, which I'm not sure how well validated, but it seems to be true, is that the higher the grade of the lesion, the more the MR might be undersampling it. So, and I don't know that's kind of a gestalt developing. I'm not exactly sure that it's true, but I do worry more about undersampling in higher grade cancers. So if we're pushing the envelope a little bit, maybe not that they have high-grade disease, but they've got 3-4 with cribriform, they've got a marginal decipher, they've got biology that seems like it actually might cause a problem, as opposed to we are doing this to reassure drop the patient-specific anxiety levels when we do PSA tests. If we're worried about a real cancer, I am more worried about the margin, and I think this idea of halo biopsy makes a lot of sense.
So the genomic classifiers in your hands, you mentioned that earlier, those are going to be help kind of deciding treatment, no treatment, if treatment, what type still?
Nothing decides treatment, okay? And if anybody uses the Polaris test out there, I cannot stand this new report that says, you do active surveillance, you do single modality, multimodality based on any single parameter, based on the genomic test. The genomic test is another piece of information that, I think of as a tiebreaker or, a decision helper, okay? Somebody that has a high-risk decipher, and I'm thinking, really high. In other words, the 0.8, 0.9 is not necessarily just into the red zone over 0.6. We just worry that this is one that's got the biologic capacity to cause problems. It doesn't mean they're likely to be metastatic. It doesn't mean, that they cannot do focal therapy. But I worry more about the background genetic substrate in that prostate, how likely it is to grow another bad one in the relatively near future. And what are the odds that we're missing something worse? I mentioned our focal cryo experience before we started doing, new generation HIFU. And out of the 100-odd cases that were collected, I think we had 3 metastatic cases. One was a patient of mine who had what looked like a perfect shot focal therapy tumor, 3+4 MR visible, exactly what we were describing earlier. His only 2 risk factors: number one, he was himself a surgeon, which of course predicted something bad happening. And the other was he had an oncotype score of 50. This was the very early days where we were doing genomic testing. And an oncotype of 50, in retrospect, is not only high risk, it's really, really high. And this gentleman, got focal cryo, had negative lesion-directed biopsies a year later, and then had metastatic disease 4 years after that. Now, would surgery have made a difference? Probably not, right? He was probably micrometastatic already at the time of treatment, but it doesn't feel very good. It feels like undertreatment, right? And, I think it's a good example of one where when the biology is revved up in prostate cancer, it's got this capacity of getting out at the microscopic level very early. Even though it's a slow-growing tumor, it can be an early metastasizing tumor, which makes it so tricky. And figuring out which those are is really critical. That's where the genomics can help. They do not tell us what to do, but they help with these decisions.
But that also doesn't tell you that surgery would be better in that setting.
No, that's what I said. No, I don't know that surgery would have made any difference, or radiation. The only thing I would say for surgery or radiation is that we would have gotten lymph nodes either removed or radiated, which maybe, would you catch the 5 cells in a node on the way to the bone? Who knows? I mean, this is all hypothetical. But like I said, it feels like a sin of omission retrospectively, right? And it's rare. These are very uncommon.
Yeah, I mean, there's some retrospective data out there that patients that have had previous bladder outlet procedures may have, and subsequently go on to receive a diagnosis of prostate cancer, that may have worse outcomes. And this idea, if you've got kind of a primed prostate, do something that induces an inflammatory. I mean, this is all like super hypothetical, but I can kind of see that mentality. Well, I kind of mentioned this earlier, and patients insisting on focal, not kind of this narrow candidate, and then they'll very reasonably say, well, if you do the focal and it doesn't work, no harm, no foul. You're just to go back in and do something standard, and I'm okay with that. How do you respond to that? Or how do you even just deal with that whole scenario? Let's just say a 56-year-old grade group 4 disease, 4 + 4 = 8, not like 12 out of 12 cores, but 2 cores, one side, and they're just like, doc, do the focal.
I think it's like what I said before. We have a responsibility to protect patients from themselves, right? And so at the end of the day, we do have a degree of knowledge in terms of the outcomes of different treatments. And there has to be, some dividing line in which we put up boundaries and we refuse treatment, right? If the patient said, I hate my left arm, doc, it's, driving me nuts, so you're going to take that arm off, right? Like, you're not, because that's not in the patient's best interest. And so I tell patients that, there will be somebody out there who will treat you. I said, that's not going to be me. And these are the treatments that I think are going to be best for you because I think it's in your own best interest. And if you are my own family member, if you are my own father, uncle, brother, whatever it is, this is what I would recommend to you. And I think that in those cases, it gives them some perspective and that this is my genuine opinion, that it's in their best interest.
I thought you were going to go to the other end of the spectrum, the high risk. I totally agree with Arvin on the low risk patients. And I think it's gotten easier over the years. It used to be this 45-minute conversation pulling somebody back from the cliff, when they've got the C word diagnosis. I think these days, most patients are familiar with the concept, although I just had a patient in clinic yesterday whose local doc had setting him up for brachytherapy, had already given him ADT for a Gleason 3+3, which is just fine. And this is not even the hinterlands of California. So it's still out there. I find it's easier than it used to be. And a big part of our job is to pull them back from that cliff. I'm in this growing minority of folks that think we shouldn't even call the 3+3s cancer because patients still get led down, this primrose path to things that they do not need to undergo. I thought you were talking about the other end. What about the guy with a Gleason 8 who's insisting on,
Well, let's talk about the higher risk end, because I actually think I see more high risk patients that are like, do a focal treatment on me.
I would apply that to both ends of the spectrum, right? I don't think it's unique to low risk. And, I have patients who come and they're like, yes, I'm Gleason, I'd rather, I'm not going to do anything at all. And then I'm like, that's up to you. That's not going to force my hand in terms of offering it. Now, we all bend our rules in some cases, right? So like I'll have some, one PIRADS 5, only Gleason 6, but it doesn't make sense. PSA is like 8. And like it's this patient has a strong family history, and you're like, there's a compound 4 in there, and the patient's really worried about it. If I'm going to offer prostatectomy or radiation in that setting, I think I have a reasonable argument to offer focal.
It is an important point that there are exceptions to every rule, right? So the PIRADS 5 with a Gleason 6, especially somebody very young with a strong family history, if you're going to do another biopsy, you're going to find something. And it's small, you can do focal, you're not burning bridges, and the guy is really on board with the ongoing surveillance, sure. 82-year-old with a small Gleason 8, MR visible, everything else negative, sure, accepting some risk. There's going to be exceptions, but the point is they should be uncommon. We all know the folks that are offering focal to absolutely everybody, or radiation to absolutely everybody, or surgery. I mean, any of these treatments can be abused.
Totally, and I wholeheartedly agree with everything you guys said. I have nothing further to add, other than just picking your brains on post-focal prostate, any experience, comments, issues, problems.
I've done salvage prostatectomies after brachy, protons, IMRT, prostatectomy once. That was interesting. And a number after, that's a different story, maybe for a different day. And a growing number after focal therapy. And I think it's a truism that it is easier after focal than after radiation therapy in general. Right? But I think it's also true that the fibrotic reactions can be very hard to predict after any of these modalities. I've done more post-radiation than post-focal so far. Radiation, sometimes you go in and it seems like they forgot to turn the machine on, or they put, expired palladium seeds in there. Other times it's like a bomb went off and there are no planes, right? Focal, likewise, you think you can make some assumptions based on how much of the gland was ablated, maybe based on the energy source, that sort of thing. But sometimes the fibrosis is minimal, sometimes it's terrible. Generally speaking, seems to be easier after ablative therapy, especially when it is hemi or less, than with whole gland radiation therapy. But that is a generalization. I think the data that are out there would support that outcomes are better with post-focal therapy surgery than with post-radiation surgery. And of course, radiation is still on the menu too for patients that recur or progress after focal. And I think there are a few issues there.
All right, Arvin, what do you think?
Yeah, I've done a handful, maybe about 10 to 15 cases post some form of ablation, either laser ablation, nanoparticle laser ablation, HIFU, cryo. And I would say in general, I think probably cryo has the most desmoplastic reaction post-ablation, but I think that these cases are feasible. And actually, the cases that I've done, they have been, deceptively less complex than I anticipated. I was really dreading doing it, and maybe it's just the expectation that you set for the case. But, you did the focal and you're responsible now. You can't say, I'm not going to go send it to my partner and be like, hey, guy, you mind taking over now? No, I'm going to take care of this. This is my patient. I'm going to take care of this patient. And so you're really dreading this case. And then, You go in and you're like, this is not that bad. And then you can get too close to the prostate. So my advice to anybody doing post-focal cases is that your local staging on MRI post-ablation is not going to be great. And you can run the risk of having extensive positive surgical margins, bladder neck invasion. So when I do, and I corrected this through my anecdotal experience, but I go wide on the ipsilateral side of the prior ablation. If I can now spare on the contralateral side, I will. I do not do bladder neck sparing of these patients anymore, even if it's, unless it was like an apical tumor and I can see clearly the bladder neck. I'm very cautious about being aggressive in the resection now.
I agree. The MR in general, I don't think is all that reliable post ablation. I think it's an important point because there are cohorts out there that are using MR and MR alone to follow these patients, without any subsequent biopsies, which is probably not yet a safe thing to do. And that applies to exactly the situation we're talking about here. I have still done bladder neck sparing, I will say, but we use fairly liberal. Make use of frozen sections fairly liberally in approaching these guys. I would also say case selection is important. There was, I agree about the cryotherapy being probably the most fibrotic. We had one few years ago now who had bilateral cryo ablation, recurrence by MR, and one of my colleagues went in to do a biopsy, and the biopsy needle was bending, trying to get into the prostate, which tells you something about fibrosis, and that patient never made it into anybody's OR for fear that a piece of rectum would come out with the prostate, I think.
Yeah, again, I think that kind of captures it. I think some of the early HIFU technologies could be a little bit offensive too, but they've really improved in my opinion. All right, so, I kind of glossed over it. I mean, first counseling, and maybe I'll just throw out my focal spiel at the high level, trifecta, 20-30% recurrences in 20-30% of patients in 5 years is kind of the numbers I have in my head. Generally, we're obviously doing this for really prioritizing sexual function preservation. Urinary function wise, the first 6-8 weeks may be a little bit rough. This is obviously very broad, but we don't expect to see the stress incontinence or frequency urgency that are associated with surgery and radiation, respectively. Does this sound about okay?
Yeah, that's about right. I do talk to them as well about, I'm very clear and explicit at the beginning. I say, this is not a standard of care treatment option. And I say, this is not a guideline concordant option. And I tell them why. I said, we don't have long-term or comparative data to say that to prove it's long-term data. So the data, the information that I can tell you is within these limitations. And then it's pretty close to what you say. I also do talk to them about salvage afterwards, about, what radiation would look like, what surgery would look like. I think that's really important. And then I do also will plug their numbers into the Memorial Sloan Kettering nomogram or whatever it is and say, this is your risk of progression in 5 years if you had prostatectomy. And oftentimes I surprise myself in that it may not be as far off as we think from focal treatments.
All right. So let's talk a little bit about modalities here. This is an ever-expanding list. Let's be honest, the indications are going to expand. It's big business, all that. Focal cryo, back when we were youngsters. Now there's a whole host of things. How do you kind of think about this? Thermal, non-thermal, or maybe just run through the list. I think there's 7 or 8 that I can just fire off the top of my heads. And maybe we can run through a little bit of advantages, disadvantages of some of these. And maybe also a hypothetical. Well, actually, I'm curious, which one do you have at your institutions? And if you were starting today and you had to make a choice, which one would you go with?
We are, as I said, we're still doing very occasional focal cryo. We're doing a lot of focal HIFU, with the focal one, and Katsuno Shinohara and Howard Wynn have really led that drive. We're starting to do IRE at UC, and the Tulsa folks have been around, but we have not yet done any cases. So that's our current menu. And we've played with other things over the years. That's the current menu.
Oh, yeah. One thing I forgot to mention during the workup is I really try to document in my biopsies if they have calcifications or not, which obviously can impact things for HIFU.
I usually do a quick Cine loop actually of the ultrasound because it gets archived into our packs. So because I'm not going to remember and what it looked like. I do also have my own syntax in terms of like what I type in: rare calcifications, extensive, none. So you kind of know what that's going to look like, but that's really important because you don't want to have to go back.
Pelvic CTs, real quick.
For Tulsa, you may need it. I think we don't. So what we have available to us is we have irreversible electroporation, or IRE. That's also known as the nanoknife. We have water vapor ablation on the Vapor 2 clinical trial, which is, for those who don't know, it's kind of like the Resume technology. Yeah, water vapor thermal therapy that has been redesigned to be able to reach the peripheral zone and treat cancer under image guidance. We have high-intensity focused ultrasound, or HIFU, of course, and cryoablation as well. And previously used nanoparticle-directed laser ablation, focal laser ablation in the past.
Okay, so maybe I'll just throw this out. I mean, calcifications, your ultrasound-based technologies become a little HIFU, TULSA, a little less feasible. Broad strokes here. Anterior lesions, anyone that you think may perform a little bit better?
Yeah, I'm not a huge fan for HIFU for anterior lesions, only because, one, I have the opportunity with other technologies that I think that can overcome any of the potential limitations. The more tissue that the HIFU beam has to travel through, the more energy attenuation you're going to get. But that's not to say that you can't get really good treatment. I've done heavy ablations in the salvage setting, and then, sometimes it's completely gone, that side. So it can treat anteriorly. But, I think I have had some patients early on in the experience where I had anterior persistent disease, and I transitioned to cryo for those IRE or any of these percutaneous procedures, even TULSA now, because this transurethral can reach anteriorly.
Yeah, I actually, confession, one of my early days, didn't realize that you couldn't kind of skip the posterior part of the prostate with HIFU and just kind of get anterior. And I had a nice, perfect candidate, just happened to be anterior midline. So we were able to do some gymnastics with the urethra back and forth.
My goodness.
But anterior midline is not going to be a good HIFU option. I think TULSA's may be a little bit more attractive.
I mean, for completeness in this whole discussion, by the way, we should acknowledge that focal radiation therapy is out there in the literature as well. Our radiation oncologists have done some of it. I wouldn't say we do a lot, but for that kind of situation, focal SBRT is not on there. Focal brachytherapy is on the list. Our crew have, like I said, have done a number of them. I actually don't know the numbers off the top of my head, but for lesions that are tough to get to with energy directed treatments, and there's a major push to avoid radical therapy, it's on the menu too.
It's like you're in my head, Matt. The next one after the kind of standard focal is focal radiation ? And we'll absolutely talk about that and maybe flame a bit. Okay, the apex. Nobody likes the apex. I don't like the apex. Is that kind of a extended spectrum ablation candidate? Don't like it. If you're going to do it, go with X, Y, or Z.
Apex is a challenge, not just for focal therapy, but for everything, right? We struggle with apical positive surgical margins. There's a lot of things converging at that point in the apex. You have external sphincter. You have a weird shape of the apex, and it can be variable. You have your urethra right there. You have your neurovascular bundles coming close to the area. And so, there's a lot of things going on, and you don't have too much give. And I do think that, there's a real opportunity for focal radiation in this. But dosimetry I always say, dosimetry is a science, right? There are people who their entire careers are dedicated to dosimetry. They understand where to place, lethal doses of radiation very precisely, really well. And so I think that in the future that will grow as it gains acceptance, and there is more data that's generated within radiation oncology as well to show whether or not it can be effective. But for apex, I lean towards HIFU because the focal volumes that are being treated are much smaller, so you can actually craft it to the prostate, the actual true shape of the prostate and capsule much better. But I do think that technologies like the vapor technology that really fills a space and is limited by capsule and anatomic boundaries will have a significant advantage in that space, because you cannot force the vapor outside the capsule and it will fill it all the way down to the distal apex in theory. So we'll see whether or not that is true, but that's the way the technology is supposed to work.
TBD.
I think the other thing that really comes into play again is baseline QOL in cases like that. Patients that already have a lot of obstruction, once we start, getting high doses of anything close to the urethra, I worry about the long-term retention risk. And also I worry more, we talked about salvage treatment, I worry more about the prospect of salvage for somebody that has had significant work done next to the sphincter, because that, when we talk about salvage prostatectomy versus a de novo prostatectomy, that's where the biggest delta is. And I think this is much more for post-radiation than post-focal therapy. It really is the continence outcomes. We, should find some wood to bang on here. Have not had a lot of rectal problems even in the post-radiation setting, but continence recovery, We can look people in the eyes today, most high volume surgeons, I think, and predict good continence recovery for the very, very large majority of men undergoing prostatectomy. Whether it's a week or 6 months may vary, but they're going to get there. If they've had prior whole gland treatment, it's a completely different story. I worry a lot in the post-radiation setting about continence, and I worry for folks that have had substantial ablation to the apex specifically.
I 100% agree with that. Yeah.
I'm not an extended spectrum ablator by any stretch of the imagination. I pretty much tell patients, we're going to expose you to the risks of whole gland treatment without, the benefits of whole gland treatment. So, we have Tulsa.
What benefits of whole gland treatment? No, I'm just kidding. Just kidding.
Yeah. Arvin and I are
I'm getting ready for the debate.
Arvin and I are debating at the Indian AUA in San Antonio. So he's just getting
fun.
So I'm the con position. He's just getting his chip shots in.
Excellent.
So we have Tulsa, which is, I think, nice for anterior lesions. Of course, there are size limitations. When you get super peripheral, you may be a little bit limited. We have HIFU, which I think is nice for posterior lesions. Cryo has largely kind of gone to the salvage setting. Juan Javier Disloge is one of my partners who got a lot of interest in this, is kind of bringing on IRE. And, I struggle a little bit, like, do we pick one and get really good at it? Do we have a few that are going to be, patient specific? What do you guys think? I mean, do you need a couple tools into the toolkit or get one and keep that knife sharp?
I don't think you can have just one. I think that, HIFU, if it's a really, anterior tumor, if you want to offer it to the, the full spectrum of patients, then one technology is going to be limiting, because there are, it's not just lesion location and volume, but there are other things. Like if you have a periurethral tumor, then, maybe IRE is the best treatment, because you have an athermal, largely athermal, I'll say, ablative modality that is not going to succumb to a thermal sink from a warming catheter or something like that. So I think that there's no one size fits all, and there's also no perfect combination. But I use you said it has gone to the wayside for you. I use cryo as really like a workhorse as a treatment, and get really good outcomes with it.
I think being good at what you do is more important than being able to offer some modality to every patient that walks in the door. Personally, there's obviously a small number of centers that are really, really focused on this and have 6 options, and they'll buy whatever is the latest and greatest. And I think I think there's a place for that kind of setup, but it also lends itself to treating the types of patients we were talking earlier about, who really should not be treated. And, inevitably there's going to be some overtreatment and undertreatment, and you get into selling modalities rather than selling, good oncologic care. And, and I think we worry a little bit about even the perception.
Yeah, I think I can appreciate both of those points. Absolutely. I think for people that really have a deep interest in this and can appreciate some of the nuances, location, size, et cetera, and have enough of a volume, maybe they become a referral center, then having some different tools makes sense.
For somebody who's contemplating getting into the space, if you're going to invest, I would say invest in imaging. It is, focal therapy, the variation across these modalities that we're discussing they're there, but they're reasonably subtle. We have a lot of different ways of destroying prostate tissue if we know what we're treating. But that if is a big one. And one thing we have not talked about, I think it's critical that the urologists who are doing focal have learned to read both the ultrasound and the MR themselves, that they've got a good working relationship with a high volume prostate focused radiologist, and that imaging piece is extremely rock solid before getting into image based treatment. That sounds obvious, but when you look at the variability in even PIRADS assignments around the country, and even within institutions, we have a long way to go in terms of standardizing imaging.
Yeah, I mean, I actually think that one of the nice things about Tulsa, for instance, which is a bit unique as it stands today, in-bore procedure, you've got your real-time sequences. There's no contouring, miscontouring, registering, cognitive this, that, and the other. There's your lesion. Every 5 seconds, you're getting a diagnostic quality MRI, and you get a little bit of a comfort. If you got 80 cc gland, let's call it a centimeter peripheral lesion in the mid gland, you're really putting a lot of faith and confidence in your contouring and your co-registry. If you're going to do something true focal, for instance, and none of us wants to swing and a miss. You know, in a biopsy, okay, you can go back in and sort it out, but, you know, treatment, it just seems extra nefarious. So maybe we'll just pause there to hear your thoughts on that. Or you ablate the whole half of the gland and just say, you know what, let's just put this one to rest.
Yeah, you kind of described a little bit about my evolution of learning and focal treatment in that, initially I was super conservative, and then I started to see some great outcomes and got a little bit more aggressive and tight with the margin. Then I started to see recurrences, and now I will try to achieve the largest margin I can without resulting in any functional deficit, right? Like in an 80-gram gland, I have much more, liberal margin to go towards the apex and go towards the base if it's a mid-gland lesion. And if it's 1.5, 2 centimeters, that's great. Especially if I'm doing cryo, it really doesn't adds 3 minutes to my case. It's really not going to do anything. It's not going to result in any greater risk of incontinence or sexual dysfunction. And I've gotten a wider margin with the potential for a better cancer outcome, because largely your recurrences or persistent disease will be at the margin.
Well, I was hoping that we could walk through the procedure, and I just don't think that's going to be feasible because there's all kinds of, considerations, regimens, and so on. But I did want to touch base on follow-up. This has come up a couple of times, and, well, I don't want to kind of put any, notions out there. What's your typical follow-up regimen? Garden variety, of course, is going to be nuanced, age, patient-specific disease characteristics, but something kind of standard. Here's what you can expect.
We typically follow the PSA every 3 to 4 months for the first year. We do an MRI at 6 months, then an MRI with a biopsy at 1 year, pretty much no matter what the MR looks like. And then beyond that, then they kind of shift back into an active surveillance type mode. So we do follow the PSA. We'll follow with MR after that. If the MR, if the biopsy was negative at a year and the MR stays stable, we're probably not going to do any more programmed biopsies, assuming the PSA is relatively stable. But there is no good PSA definition of recurrence here, despite all these attempts in the literature to use the Phoenix definition, which is meant for radiation therapy. There's this Heidelberg definition. I mean, given how variable that term focal is, as we talked about at the beginning, there's no way to use PSA consistently across all these different patients as an indicator of outcomes. So it's not safe on its own. And I would argue neither is MR today. Maybe at some point MR plus PSMA or next generation MR with better AI, better experience with reading MR after focal therapy. We may get there, but the biopsy at a year to me is critical.
Yeah, what do you think, Arvin?
I actually have a question for Matt. Matt, what do you do in those patients in whom you have untreated Gleason 6? Maybe on the contralateral side, you said you do allow for that. Now, do you feel compelled to do a protocol biopsy there with all other things being stable in those patients on surveillance?
Because Matt doesn't think they have cancer, so he doesn't need to do anything about that.
All right, so since you're poking that bear, I'll take the bait there, which is to say that even if we don't call it cancer, we absolutely still have to follow it. So even those of us that are very pro in this rename it debate would say active surveillance does not change, okay? You call it something other than cancer, it still absolutely needs active surveillance. But that surveillance we're starting to tailor. So, the UK, they don't even do biopsies in active surveillance. They're following it entirely with MRI, which I'm not sure we're there yet. But the more follow-up you have on the tumor or on a given lesion, the better we feel about the imaging. So we had a study out a couple of years ago from Carissa Chu, who's just rejoined us as faculty, looking at exactly this question of what's the NPV for MRI for not missing high-grade disease. And at the confirmatory biopsy, so they've had a diagnostic, now they come to us for the confirmatory, it's not that great. MR missed about 25% of upgrading events, and it's even higher if the PSA density is high. On the other hand, once you've had the confirmatory, the downstream biopsies 3, 4, 5, and on down the road, the NPV is much higher, and if the PSA density is low, it's over 90%. So for following that 3-3, that we're intentionally not treating on the other side, they get the biopsy at a year. Okay, so if that biopsy shows that the lesion has been effectively ablated, and we just find the same scraps of 3-3 on the other side that we found before, we're going to follow that primarily with imaging. So the protocol biopsies, we're trying to do less and less of. And every once in a while these days, I'm seeing somebody who's like 6-8 years since their last biopsy. And I kind of say, well, I feel like we should do a biopsy because it's been so long. And if the imaging is stable and the PSA has been stable, invariably we find nothing, or we find a little 3-3 again. So I'm getting more and more comfortable using imaging alone for these ones that have already declared themselves to be stable.
Well, I think this is an area that's really exciting and ripe for further exploration. I mean, PSMA PET has kind of popped up a couple of times. I mean, how nice would it be if you have something that's PSMA PET positive and then it goes cold? I mean, some of the secondary cancer screening biomarkers, you can get a pre-ablation and a post-ablation if they seroconvert or uroconvert or exosome convert to negative, maybe feel kind of good about it. And I do think that this is going to be like a bit of a shared decision-making, kind of like surveillance. And I really had an aha moment on a previous podcast with Arvin, Minaj, and Kara about, really tailoring active surveillance for shared decision-making. I think we may head there. And this isn't like a cop-out to never have to do a biopsy or something like that. But, if it's, the genomic classifiers, the PSMA PET, some other test that may decrease the pre-test probability of finding anything kind of meaningful, if we could safely avoid biopsies, why not? Well, I mean, I think we've covered a lot, the practical execution, maybe we'll say that for another day, but I would love to just maybe wrap up with some parting thoughts. Arvin, perhaps we can start with you, and then Matt, get them from your end. We'll be respectful of the time differences here, start from east to west.
First, I'd like to, thank you, Aditya, again for the opportunity to be here. It's always, fun to talk these things out and have other people kind of hear our perspective on things. As kind of final thoughts, I'd say that, there's a huge promise for focal therapy. But I think that now that we are studying it much more closely, that we're seeing value in it as a potential option that will help guide us to it in the right patients. And I think that we can come dangerously close to being our own worst enemies and try to look for the short-term gain, which can ultimately, really harm a treatment option that could have some real viability. But the future is bright, and I think it's really promising. And I think the indications will continue to expand. And I'm looking forward to the future.
I love that. What do you think, Matt?
There's this old saying that in surgical oncology, biology is king, and all the surgeons, and here you can throw in radiation oncologists and focal therapists and everybody else are the princes trying to overthrow the king, often to no avail. I think ultimately it comes down to understanding the cancer more and more at the biological level. I think the role for focal therapy is clearly going to grow as we can identify those tumors that are actually confined to the prostate, and we can visualize them with imaging, increasingly with functional imaging, as our focal modalities get more and more guided by real-time feedback from imaging. Clearly, it makes sense. Okay, and you look at the history. Everyone always draws the analogy to breast cancer and lumpectomy, taking over from mastectomy. Obviously, there's a lot of different considerations in prostate compared to breast, but nonetheless, the idea of treating the tumor rather than the prostate makes a lot of sense for a certain band of cancers. And as we're able to identify that band, figure out the ones that need treatment and yet need less than total treatment and pelvic treatment, as we can identify those and target them, of course, the role here will continue to grow. But the only way we're going to identify those tumors is to take this seriously, to, as we said at the beginning, put patients that are undergoing focal therapy in a registry, on a trial, collect the data, be honest about our outcomes, and constantly be striving to improve those outcomes with research and improvements in our treatments.
Perfect. And I think, the things that jumped out to me are this is something that you can acquire as a part of your armamentarium and skill set, even if you weren't trained on it. There's a lot of, I think, amazing people out there. We had Hal come down here and proctor us for some of our first Focal One cases, which is tremendous. And in the same breath, it is incumbent upon us to be thoughtful, to develop expertise, identify the patient, the cancer, the imaging specific features that are going to really help us identify and help the right patients and make sure we're not hurting anybody along the way. Well, Arvin, Matt, it's been great. Thank you so much for your time. Look forward to seeing you in San Antonio, if not before. And Arvin,
it's a pleasure.
Gloves up. Let's see what we get.
I'm ready for you.
Thank you so much for listening. If
If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _backtable on Instagram, LinkedIn, or Twitter.
Backtable is hosted by Aditya Bagrodia
And Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.